Yeah. Hi students. I am Dr. Badrinath. In this video, we will see the DDI, drug interaction classification along with the examples. Right? Okay. If you see number of deaths are already reported. Number of deaths are already reported in the history due to the drug interaction. If you are not prescribing well, if you are not checking, is on the way. Lord Yama is on the way. Okay, he will come and take out the patient to the mortuary or to the heaven or hell. Okay, right? Okay, yeah. See, significance of drug interaction is already completed, and I have uploaded the video. In this video, we'll see the classification along with the example. Okay, definition, and all already I have explained in that video itself. Right? Okay, yeah. Here, drug interaction, we will see the pharmacokinetic drug interaction here. Next video is pharmacodynamic interaction that we will see now, right? Here you can see one drug is interacting with the another drug. It leads to death. It leads to death, right? Yeah. If you see the classification of the DDI, drug interaction, or mechanism of the DDI, or types of the DDI, anything they may ask in the examination. So don't get confusion. All are same only. Mechanism, types, or classification. Mainly two things are there. We know that pharmacokinetic interaction, pharmacodynamic interaction. First of all, you have to write in the examination. We know that pharmacokinetic interaction, pharmacokinetic means what our body will cause is to the drug. Okay, what our body will do, it absorbs the drug, it distributes the drug, it metabolizes the drug, and finally it excretes the drug. That we know very well. During this process, ADME, there is a chances of drug interaction. Okay, see, absorption of one drug may interact with the absorption of another drug. Keep in your mind, but absorption of one drug cannot alter, cannot interfere with the distribution of another drug. Absorption will be absorption of another drug. Distribution of one drug disturb the distribution of another drug. Metabolism of one drug disturb the metabolism of another drug. Excretion of one drug disturb the excretion of another drug. But absorption of one drug cannot interfere with the distribution of another drug, like that. Okay, same within the same region only drug interactions are takes place. Okay, we know that ADME. Only pharmacokinetic interaction along with the examples that we will see. This is only a big. Pharmacodynamic interactions are very small that I will make in another video. But in the class, in the examination, you have to write the both. So pharmacodynamics means what a drug causes to the body. It shows its therapeutic action, side effects, everything it shows. There is a 3: synergistic, additive, antagonist, that comes in the next video. Yeah. ADME, absorption, distribution, metabolism, and excretion. First, we'll start with the absorption. In the absorption, how the DDI will happen, drug interaction? Altered GIT absorption. So absorption takes place, we know that from GIT only, gastrointestinal tract. We know very well. So during this process, during the absorption of atom, there is a 5 chances are there. 5 chances. 1, 2, 3, 4, 5. All these 5 chances are very, very important. First one is the altered pH. Altered pH. All these points we will see one by one with the example. Simple example. One example is enough to write in regular examination, right? Altered pH. Altered intestinal flora, gut flora, complexation and chelation. Drug-induced mucosal damage. Mucosa will be get damaged. And finally, altered motility of the GIT, motility movement. Fast movement, slow movement. Okay, now we will see first one, altered pH. See, pH, it ranges from 1 to 14, that we know very well. Stomach, this is the stomach. Okay, see here, stomach is acidic in nature. It always favors the absorption of acidic drugs. That point I have already told number of times. Here also I am repeating, stomach is acidic in nature. It mainly, acidic drugs are absorbed very well from the stomach. Acidic drugs, okay. Now see, this is a tablet. What is this tablet? Ciprofloxacin ketoconazole. See the pointer? It is a ciprofloxacin tablet, or it may be a ketoconazole tablet, any tablet. These are the acidic in nature. These drugs, ciprofloxacin is acidic in nature, ketoconazole is acidic in nature, well absorbed from the stomach. Okay, see, absorption of acidic drugs are high from the stomach always, because the reason is acidic environment will be there in the stomach. It causes the drug remains unionized form. Drug will not be ionized. Acidic drug will not be ionized in the stomach. Okay, since it is stomach is also acid, drug is also acid. So there is no ionization chance. So unionized drugs are absorbed well. That we know very well. Okay. So ciprofloxacin, ketoconazole are acidic drugs in nature, well absorbed from the stomach. Okay. Now what happen if you are prescribing these drugs, ciprofloxacin, ketoconazole or any acidic drugs, along with the antacids? See here, this is an antacid. Antacid with ciprofloxacin, antacid, ketoconazole. Or antacid will increases the, we know very well, pH will be increased. It will be changed to the alkaline. Acidity will be decreased. Alkalinity will be increased. Isn't it? So pH will be increased. So what happened? Stomach acidity will be reduced. So automatically absorption of this drug, ciprofloxacin, ketoconazole reduced. See here, see the arrow mark. How the absorption? A stands for absorption. Absorption is very big here. Okay, when you are taking a alone, but here you are taking a antacid along this tablet along with the antacid. This tablet along with the H2 blockers. H2 blockers we know very well, it blocks the H2 receptor. So acidity secretion will be decreased. So what happened? pH will be increased. Same just like antacid only. Okay, antacid, H2 blockers both are almost same because it increases the pH, decreases the acidity. So if you are taking the tablet, this tablet along with the antacid or along with the H2 blocker, see how narrow the arrow mark. Absorption is decreased gradually. It leads to failure of the ciprofloxacin therapy, failure of the ketoconazole therapy, decreases the absorption, decreases the bioavailability. So that's why don't prescribe these acidic drugs along with the antacid or H2 blocker. That is the first one. Altered pH. pH of the stomach is altered. Altered. That point you have to keep in your mind, right? Next, number two. Altered intestinal flora. Intestinal flora means all the microorganisms which are present in the intestine. That we will see now. Generally, intestine consists of the flora. Okay. See here, this is the intestine. Large intestine, small intestine, and these are all the microorganisms which are present in the car. It is called as a flora. See, these flora in generally 40% of the digitoxin tablet were metabolized by the flora. That's why digitoxin absorption is poor here. See the arrow mark. Absorption of digitoxin is very poor because of the flora. Flora decreases. 40% of the digitoxin will be wasted, metabolized by the flora. Okay, now okay. If you are, that is general thing happen, that is a good flora only. But if you are taking an antibiotic, we know very well antibiotics will kill the most of the bacteria. Intestinal flora will be get cleaned, very clean. All intestinal flora organisms will be died. So when it is died, entire digitoxin will be absorbed. When the entire digitoxin is increased, it leads to 40. See the arrow pointer, arrow mark. How much big is their arrow mark? Digitoxin absorption is very good. This is antibiotic. See here, antibiotic. So there is no single microbial flora, single organism. So entire digitoxin is absorbed. So 40% increase in the digitoxin blood concentration leads to digitoxin toxicity. So whenever you are giving antibiotic with the digitoxin, you can reduce the digitoxin dose. You can reduce it. Otherwise, it may leads to toxicity. It may leads to higher the heartbeat of the contraction, and it leads to cardiac arrest finally. Antibiotic digitoxin. This is called altered intestinal flora. Here you can see altered intestinal flora. Yeah. Next, very well-known example, calcium and tetracycline. It forms a complex. That's why this is called a complexation or chelation. See here, this is tetracycline alone, well absorbed. See here, how, see the arrow mark, absorption is excellent. Tetracycline. But what happened when you are taking along with the milk or coffee also, because coffee also consists of milk, tea also consists of milk. Coffee, milk, tea, whatever it may be, or calcium. Any calcium tablets also, don't take calcium tablets also along with the tetracycline. What happens, see, calcium which is present in the milk or in the vitamin tablets of the calcium, it forms a complex. See the complex here. This is very simple. Here it forms a very big complex with the calcium. See, absorption is gradually decreased. See here, this is a big arrow mark. Very small arrow mark. Absorption drastically reduced. So tetracycline forms a complex with the calcium of the milk. This formed complex cannot absorb from the GIT gastrointestinal tract. It leads to therapeutic failure of the respective infection. Okay, tetracycline, even the patient is taking tetracycline, it becomes waste. Right? Now, drug induced mucosal layer damage. See here, this is a mucosal layer, muscle layer, mucosal layer, and a submucosal layer, that is a mucosa. So like this. See here, very good. 4 layers are there. 1, 2, 3, 4. All 4 I have here shown. Here, what happened? This entire flora. See, digitaxin is very good absorbed from the stomach, very good from the GIT when mucosal layer is healthy. But here, see the things. This mucosal layer or muscle layer, see, this is a mucosa. This mucosa, whatever it may be, this entire 4 layers will be get damaged. See, by the anti-cancer agents like cyclophosphonates, vincristine, vinblastine, anti-cancer agents causes the damage to the mucosal layer. This mucosal layer damage, it leads to decreases the digitaction. See the arrow mark, very small, very small, because mucosa is not ready, because mucosa is damaged by the drug. So don't give anti-cancer agents along with the digitaxin. Okay, because during the absorption, muscles, your muscular layer or mucosal layer will be get damaged. Number two, uh, so digitaxin toxicity when reduced, it leads to cardiac arrest. That we know very well. Digitaxin therapy will be get failured because digitaxin absorption is poor. Next is altered motility. See here, motility, GIT motility is very thin here, narrow, very slow GIT motility. Here, very fast. See the arrow mark thickness. Okay, so decreases the GI motility. Okay, what happened? Decreases the gastric emptying time. More time, it will be entered in the stomach only, the drug will be. Okay, so it decreases the absorption of a drug from intestine because it slowly will go to the intestine, your stomach contents or food or tablets, whatever it may be. So it decreases the bioavailability, definitely. And here what happened? GI motility increased here. So what happened? Immediately it will be enter into the fecal matter, drug molecule, because motility is increased like this, very fast. So before getting the absorption itself, absorption is decreased. See here also absorption decreased, here also absorption decreased. Because most here from intestine only absorption takes place. Here most probably it is there in the stomach only. So it is not there in the intestine. Okay, so slow absorption, slow onset of action, everything is on the slow bioavailability. Here also it decreases absorption because immediately it enter into the fecal matter, right? That is absorption is over. Now you come to the distribution interaction. During the distribution, what happened? I already told protein binding. This is a albumin. Albumin consists of a 4 site, site 1, site 2, site 3, site 4 for the absorption. That is for binding of the drug. Okay. Now what happened? Warfarin and aspirin. These two, this is red color is a warfarin. See, very having a low affinity towards the binding site 1, low attraction force. Whereas aspirin molecules are having a higher affinity for the site 1. So there was a competition along for warfarin and aspirin. Running race, just like a running race towards the binding site. Aspirin having a more affinity. That's why what happened? Aspirin, see here situation, aspirin is having a more affinity than the warfarin towards the site 1. So what happened in the situation 1? If patient is taking the both drugs simultaneously, aspirin and warfarin along, aspirin binds faster than the warfarin. So it leads to increases the warfarin free drug. Aspirin will bound to the protein. So free drug of the warfarin increased. It leads to more therapeutic action, more toxicity. It leads to dangerous for the patient. So warfarin toxicity. Second case, see, first patient is consumed warfarin. Okay, so warfarin go and binds with the site 1. Now patient is taken aspirin. Now after a gap, 1 hour gap or 2 hour gap. What happened? Warfarin, which is already bounded, it will be displaced by the aspirin. That's why this is also called as a displacement reactions. Okay, aspirin go and it removes the warfarin from the binding site. So free drug concentration of warfarin is increased. It leads to again warfarin toxicity, coma. Patient will be in the coma. Hematotic damage is there. Anticoagulant flow will be more increased in the. It leads to damage of the internal hemorrhage, that and all. That is about the distribution interaction. Now you come to the altered metabolism. Enzyme induction. See here, induction means increasing. Enzymes, what enzymes? Metabolic enzymes are increased. Metabolic enzymes are increased. Now I will show you one example. See here, these are the coumarin drug molecules. Many are there. Enzyme, coumarin metabolic enzyme. This enzyme will take the each coumarin particle and break down into two pieces. Okay, like that metabolites will come. This is a coumarin metabolites. This is a coumarin drug molecule. Okay, so this is a coumarin metabolic enzymes. Okay, see, enzymes are less. Coumarin drug molecules are more. Okay, so that's why very less speed is going on now. Now what happened? This is actually a situation going on. Now what happened? Barbiturates, enzyme induction will happen. This barbiturates are, that's why it is called as a barbiturate is called as a inducer. It increases the coumarin metabolic enzyme. See the where is the barbiturates, where is the coumarin? See, barbiturate increasing the metabolic enzymes of the coumarin. See how many are there enzymes now? 1, 2, 3. Number of enzymes are increased. So that's why coumarin drug molecules are very less. Immediately entire coumarin drug molecules are metabolized. So even though you are taking coumarin tablets, it is waste along with the barbiturates. Don't take barbiturates. Don't give barbiturates along with the coumarin, because coumarin will be metabolized very fast. Very fast. Okay. So that's why the inducer, name keep in your mind, inducer. All these are the inducers. Barbiturates don't take with coumarin. Barbiturates don't take with phenytoin. Barbiturates don't take with cortisol. Barbiturates don't take with testosterone. Like these are the groups. Alcohol. All these are the inducers. Okay, all these inducers increases the metabolism of all these drugs. Okay, that's why don't take with this combination. Carbamazepine, self, self itself, it increases its own enzymes, just like a suicide, self-suicide. Okay, self-goal. That is one of the biggest problem of the carbamazepine. It is very important also. If you are taking carbamazepine, it's that's why high dose we are taking carbamazepine. Actually, very low dose is required carbamazepine, but we are taking more. Why? Means carbamazepine, it increases its own metabolizing enzyme. Okay, see, carbamazepine, own carbamazepine metabolating enzymes are more. That's why carbamazepine metabolites are decreased. That's why you have to take a high dose. What we are taking is a high dose actually. Okay, now enzyme inhibition. This is very good combination. See, number of enzymes are more here. Phenytoin drug molecule. That's why more metabolic products you have observed here. Only less drug molecules are here. All these are the phenytoin metabolizing enzymes. This is actually going on, phenytoin. Now what happened if you are taking phenytoin along with the PAS, PAS, para-amino salicylic acid, it is called as an inhibitor. It inhibits the enzyme. See how many enzymes are here. Now see, it is decreased. Enzymes are decreased. So that more accumulation of the phenytoin drug molecule. See, number of phenytoin molecules are there. Very less metabolites are there. Opposite to that of the previous one. So what happened automatically? Phenytoin free molecules are increased. So it leads to phenytoin toxicity. So you reduce the dose. Whenever you are giving a combination, reduce the dose of the phenytoin. That is very, very important. Okay, give PAS with the phenytoin. PAS increases the concentration of phenytoin. So all these are the inhibitors. Just like that cycle inducer, here inhibitors, Myo inhibitor, coumarins, allopurinol, PAS. These don't, you can take with this combination, but what happened? Free concentration of this drug will be increased. So you reduce it somewhat little bit. You can give the combination. Now excretion. See, absorption is over, distribution is over, metabolism is also over. Now you come to the excretion. During the excretion, we know very well there was a three process: glomerular filtration, active tubular secretion, and here reabsorption. Three are there. Now we will see only active tubular secretion here. See, generally penicillin are secreted. Glomerular filtration also, it is very less secreted. Penicillins here, keep in your mind. Strongly penicillins are secreted, cephalosporins secreted in the proximal. This is a proximal convoluted tubule. This is a distal convoluted tubule because it is having a very distance. That's why distal, distance is there. This is a proximal. First, that is a primary, proximal. Okay, primary convoluted tubular or proximal convoluted tubular. Penicillins are secreted well here. Penicillins will not undergo the secretion from glomerular filtration. That point you have to keep in your mind. No. Penicillins are secreted well because it is a hydrophilic molecule, well secreted from glomerular filtration, well secreted. Penicillin is water soluble molecule only. Along with the urine, it will be excreted well. Okay, you correct that point. Okay. So penicillin cephalosporin secretion is also very good. Here, see the excellent thing is there. Penicillin alone, if you are taking, see the very thick arrow mark here. Now what happened? Penicillin, if you are taking along with the probenecid, probenecid decreases the penicillin secretion. So penicillin will not be secreted into the urinary tubule. So penicillin will be there in the blood for a longer time. See, penicillin will be there in the longer time in the blood. So penicillin concentration will be increased. It leads to synergistic effect. So it is very good combination. You can reduce the penicillin dose because synergistic combination is there. Why means probenecid decreases the active tubular secretion of the penicillin. That is the strongest point. That's why see the thick mark. See, it becomes very thin here. Whereas here you can see very thick. So that's why this is a super combination. Penicillin dose can be reduced by 50%. Otherwise, it leads to penicillin toxicity. This is a super combination of the probenecid along with the penicillin. Okay, don't give as such. Give, instead of 2 tablets, give 1 tablet. So just like a 50% offer, just like Amazon offer, 50% of penicillin dose you can be reduced by the. This combination is super, just like chicken biryani along with the Coca-Cola, right? The same. Now what happened? Excretion interaction, tubular reabsorption. This is the last example. You see here, tubular reabsorption, salicylate is very reabsorbed well. Okay, now that's why very reabsorbed into blood. So only less salicylic acid will go into the urine. So reabsorbed well. So it is showing its action. Now what happened now? Salicylates, if you are taking along with the antacids, what happened? Salicylate reabsorption into the blood is decreased. So more amount of salicylate will be excreted through the urine. So what happened? It leads to failure of the salicylate therapy. Antacid decreases the absorption of salicylate and it increases its clearance will be increased. So it leads to therapeutic failure of the salicylic acid. So increase the dose here, salicylate dose. Okay, so I have end my session here. All we saw along with the each one example. That classification, everything is important for regular examination. This drug-drug interaction comes in many subjects, not only in biopharmaceutics. See here I am uploading this video in the biopharmaceutics, but it comes in a clinical pharmacy also. It is B.Pharmacy, M.Pharmacy, Pharma.D, all the courses having this thing. Okay, right.